Let me not take any more time so that we can hear Leah's talk. Leah Reich is a recently minted PhD in sociology. She's going to be presenting research that was packaged in her dissertation. She's also an experimental ethnographer at Experience Experiments, a company with which I have an affiliation as well. And not only is she that, she's an inspired photographer, and she's also good at giving talks, so I'll give her the mic.
Hi everyone, thanks so much for coming. I'm Leah. This is my talk, On or Off the Record, the Effect of Organizational Culture on the Physician Experience of Electronic Health Records. As Paul mentioned, I'd stay away from that one. As Paul mentioned, I did recently finish my dissertation and my PhD in September. I'm newly minted, and a lot of you are wearing I'm hiring. I feel like we should also get stickers that say I'm looking, so maybe we can talk after my talk. So when I tell people that I did my dissertation research as a sociologist on electronic health records, one of the first things they always say to me is, how did you make it to electronic health records? And it was an interesting path, but I have for a very long time been very interested in the intersection of technology, culture, and interaction. About 11 years ago, I was an advice columnist for video gamers. At IGN.com, I was Ask Leah. And as Ask Leah, I had this really amazing sort of fortune to be able to learn what it was like to address one person's problem, but to frame it in a way that resonated for a lot of other people. Because it turns out that a lot of change can be very cultural in nature, right? Some of the changes that we have to go through in life, it's not just, well, I have this one problem, but we have to think about the ways in which we deal with it in whatever culture we're embedded. Maybe it'll be an organization, but change can be very cultural. And that kind of made me think about how technological change can be really cultural for a lot of people. We don't just suddenly switch to saying, oh, hey, I'm going to use this new tool, but in a lot of ways, it's really a cultural shift for many people. I also became interested in how people navigate significant organizational change, one that's professional and cultural as well. And it was this sort of question that I was thinking about when I was studying org theory and thinking about technology, and I would say, well, if two companies merge or there's the big departmental shifts, how do people change? How do people get from point A to point B? And there's always somebody who says they don't, haha, it's very funny. Except they do, right? Maybe they leave. Maybe they don't make it all the way through. Maybe they have a problem. Maybe they have a really successful transition, but how do they do it? What is that change like for people? And I found my way to an organization that happened to be implementing electronic health records from a totally paper record system in 2007. And that seemed like a really interesting intersection of all of these problems. On top of that, there was also the problem of a contested space, a lot of other cultural changes going on. And electronic health records in general they're just fascinating. I mean, yes, they're a major part of health IT, which is a very hot topic right now. As I was told repeatedly when I was doing my dissertation, that's a very timely subject. But they're really fascinating as a window into the assumptions and expectations that we have of healthcare, whether we're a practitioner or a patient. Of local practices and routines, of professional power and identity, of the assumptions that we make about what technology should and shouldn't do, how it should behave. So these are all things that I became really interested in, questions that I still have and I'd still like to answer. So one of the first things that we should probably talk about is what is an electronic health record? That, it turns out, is easier to ask than it is to answer. When I was finishing my research, sort of midway through and getting started on the dissertation, I thought I'm probably going to have to operationalize electronic health record. And it turns out, as you start reading and you start going down that rabbit hole, there are so many definitions that people have of what an EHR is. What is an EMR? Can we call an EHR an EMR and an EMR an EHR? Are they different things? Are they the same thing? A lot of the definitions describe what an EHR is more than define what they can do, what their potential is. And I thought this was a really interesting kind of beginning to the problem, is that how do we introduce a technology to a population and ask them to adopt it if we can't really say exactly what it is? So one of the better definitions that I found is the intersection of the following criteria. You integrate data from multiple sources, you capture that data at the point of care, and you support caregiver decision making. So the EHR is the framework with its multiple information technology components, but it's also what the core functions that technology is intended to perform, right? And then, of course, like I said, there's a debate over EMR versus EHR as the preferred term. That debate's been raging for 15, 20 years. And it's kind of an interesting one. I won't go into it now because I don't have time, but I chose to call them EHR because that's what people were calling it more predominantly at the time when they were implementing it, particularly in the organization where I was. We can discuss further whether that was the right choice or the wrong choice, but now, maybe later. There are also variations in terms of the functionality of electronic health records. They range anywhere from very, very basic, collecting some demographic data, some notes, all the way up to fully functional, supporting caregiver decision-making, e-prescribing, sending your labs out, having your labs come right back in, the entire package right there in front of you as a clinician. So defining it, it has to include what the potential of the technology is and how much it can support what the doctor or the nurse practitioner is trying to do. It's important for me to point out to you that I conducted my research before ARA, before 2009 with the stimulus bill. So there's sort of been this watershed moment for health IT and for EHR, which was when, in 2004, Bush says, we have an initiative. We need to get everybody in electronic health records. We're going to do it by 2011, right? And then all of a sudden it's 2008, and we're not really that close to it. And that was a nice initiative. And so then it becomes a mandate under Obama. We're going to get everybody on electronic health records at 2014. So in the stimulus bill, there was millions of dollars earmarked to improve technology and health IT and build a workforce that could train people in terms of health IT, could use it better. And then there was money set aside for doctors and health organizations, smaller ones, the ambulatory care clinics in particular, that if they adhered to a certain set of standards that had yet to be defined, and that later became known as meaningful use, they could earn some money there. So there was money set aside to help people make it through the transition to electronic health records. And one of the reasons for this is that one of the major obstacles in transitioning to electronic health records is the prohibitive cost. It's not the only one, but it's one of them. So I did my research in 2007, starting in 2007, really did the data collection 2008, 2009, and then all of a sudden this happens. So the dialogue that we have before and after is really, really different because now all of a sudden there's this big explosion in what's available, how people are talking about it, the definitions that are going on. Meaningful use is a really important thing that people talk about. None of that was even, I mean, it was just beginning, but it wasn't a part of the vocabulary that people use every day in talking about EHR. So, and initially, in addition to that, in the broader context, you have all of these other changes that are going on in healthcare more generally, right? So, you guys know, go to the doctor, private practices, significantly fewer than there used to be, much more managed care, private practices are joining networks. There's a really big shift in the ways in which doctors exist, right, in our consciousness. Are they in big vertically integrated healthcare systems? Are there networked groups? Many doctors, like 50% of doctors still work in offices, but those offices are no longer privately owned. Many of them are not. Very few of them are now. And it's not a very, it's a pretty hostile time to have a private practice. There's a lot of overhead, there are a lot of costs, and EHR added to that. Health IT in 2007, 2008, adoption rates were very different. I'm grabbing, these are the most recent statistics that were released from the National Ambulatory Medical Care Survey. 34.8% in 2007 versus 50.7% this last year of any type of EHR at all. But some of the data that I tried to find in 2006, 2007, 2008 was very, very different. It was hard to find a single data point that anybody really reported regularly. You would get 25%, and then I would try and track down where did that 25% come from, because I couldn't just quote a newspaper article. I had to know what survey that was from, and I couldn't find the survey anywhere, and I would find 1.3, 13%. So it's been this really sort of varied experience for health IT and for EHR transition and adoption. But it's really growing exponentially now because there's this push to get everybody on. There's money, there's meaningful use. We have to meet these standards, we have to go. So it's kind of in a gold rush. So, my research. I conducted a longitudinal, multi-method, ethnographic case study of the clinician experience from transitioning from a paper record system to an electronic record system. It's important for you to know that this was a totally virgin implementation. That means they had a bunch of charts, thousands of them, and they had an electronic health record system. And somehow, all of that data had to get into the electronic health record system, and the doctors had data on the system, and everybody. And they did it. When I started conducting my research in earnest in early 2008, they had yet to start populating the system with data, and they went live in August 2008. This is one small point in the constellation of interesting things that I saw as a researcher. So it's useful to know that because this is the experience that the doctors had, and I think that when you think about, well, why don't we just get everybody on electronic health record systems? It's hard to stop and take a step back and say, you have to populate all of that data. You have to populate all the systems with data. Your data has to get in there, and it can't just be like, well, this person has asthma. What type of asthma do they have? What do they have? How long have they had it for? What types of medications have they been on? Who's going to populate that data for you? So this turned out to be a really incredible problem. So there were a lot of considerations, as you can tell. I looked at context, I looked at routines and local processes, and I looked at conflicts. There were a lot of considerations I took, and these are some of them that are relevant to today's talk. I went into the research site using kind of a modified grounded theory approach. I let the theory guide me in collecting the data, and then I looked through the data as I went, and I refined my research as I went based on what the data was telling me. But I did have some theoretical considerations, and I had a couple of ideas of maybe what I might find that informed the research that I did. So the theoretical considerations, there were multiple. These are the three I've pulled out for tonight. There is the negotiated order, conflict, and culture. And for those of you who are not familiar with negotiated order, it's a concept that was first introduced by Anselm Strauss and his colleagues in the 1960s when they're studying a hospital. And it's this idea that people of varying professional statuses in an organization have these tacit, sometimes unspoken agreements about how work is going to be performed. You know what your role is. You're a doctor, you're a nurse, you're a technician, these are your roles, these are the ways we interact around those roles, this is how we do our work on a regular daily basis, right? So in some ways, negotiated order is a way that people and organizations experience stability, but in another way, it's a way in which they also experience incremental change, because every single day you renegotiate that order in your organization. You walk in and you say, I might be the doctor, but you're the nurse, and today we have to do a couple things differently than we did before. So we're constantly renegotiating that order, and that can sometimes cause incremental change over time. In the 1980s, Stephen Barley comes in, and he looks again at another medical situation. He looks at a couple of radiology departments implementing technology, and he says, as many of you probably would agree with, oh, technology is also a social actor. People sometimes have to renegotiate their order around technology. And we have to think about technology as this social actor. It's really important for us to do that. And he also says that technology can be this opportunity for us in organizations and elsewhere to create change. We can see it as the opportunity to sort of bury ourselves back into that old negotiated order and just never, ever, ever change. It can become more stable, or it can be this opportunity to really create a new sort of order for ourselves in our organizations. As far as culture goes, this is the other one that's important to define. I define culture using Ann Swidler, who is a sociologist at Berkeley, and she defined culture starting in the 80s as this idea of the toolkit. We all carry around these repertoires of traditions, of symbols, of ideas, and in every context that we're in every situation when we're confronted with something, we draw on that repertoire to create what are called our sort of these actions that we have to create, right? And our strategies of action, that she calls them. So these strategies of action are going to affect how we perceive things, how we navigate our way through processes, all of the things that we do based on the cultures that we have experienced and the repertoires that we've built coming from all of those different areas. Barley again says, and when technology comes in, it's really important to think about what was the context like before, what was the culture like, because that is going to tell you a lot about how people react. So this is where I'm coming from in doing all this research. And where did I do my research? Transitions. This is my pseudonym, one of them. So it's a recently formed group of networked ambulatory care sites in Northern California, urban and suburban. There's a variation in the types of care sites. it is recently formed. That's important also to know, is that not only are we kind of going through this transition in a very rapid clip, by the time we get to go live, the organization will have existed for 3 years. These were all previously private practices or physicians who had worked in small private groups, who had left them, their groups had dissolved, they decided they wanted to gain employment elsewhere, but they didn't want to go to a large managed care system. So that's another cultural change to think about, right? What are these different sort of authority structures that people are dealing with? Do they feel like they're comfortable in terms of who their bosses are and all of these things are going on? Because the way in which this organization is structured, it's a very California type of healthcare organization, right? You've got your medical group, which is Transitions Health Group, the for-profit medical group, and the doctors work for that, and only the doctors, and that is it. They're all the employees of that group. Then over here, you've got Concerned Physicians Foundation, which is the management services organization. And under that group, support staff, MAs, billing, medical records, administration, everybody else, and they provide the operational support, ostensibly. So you have these doctors who had previously been in charge of their staff, in charge of running their own organizations, whether successfully or not. Now all of a sudden, they're employees. And not only that, they have to develop a different relationship with the people who work for them, right? If you've ever had somebody who worked for you, you know that there are different ways that you can say, here's how I want to encourage you to do better, and here's how we have to deal with a job that you're not doing well. But if you're no longer technically that person's boss, that really puts you in an awkward position. I'm your boss, but not really. You're my MA, but I can't fire you. I can't incentivize you. There's nothing that I can do to say, please do a better job. So these clinicians are experiencing this series of incredible cultural changes, right? And they're affiliated with the larger regional healthcare provider called Jumbo Medical. So in doing my research design, I decided there was no way that I could study all 18 sites in depth and then graduate before retirement. So I chose 6 sites to spend the bulk of my time in. I worked in them, so there was 2 primary care, 3 OBGYN and 1 neurology, but I was able to visit 15 of the sites total. 3 I did not, 1 closed, and 2 had very sensitive patient populations. I didn't want to make them uncomfortable because I was spending a lot of time in these offices. So I was able to visit and do research in 15 sites total, but I really spent the bulk of my time in 6. So primarily, my focus was on physicians, but there are many other clinicians who work there, so they were included in the study. There were some other nurse practitioners and physician assistants as well. There was about 75 total, although that number is kind of hard to pin down because people came and went. There was turnover, so there were people who were being added sometimes. And sometimes when you're doing participant observation, you can count how many interviews you do and how many surveys you do, but in participant observation, there's this, have you gone through your notes? Do you know every single doctor that you saw? So there was about 75. There was turnover, people left. And clinicians don't work in a vacuum. So I made sure to include everybody that I could in my study. Support staff, MAs, billing, administrators, IT, you name it. The only thing I didn't include in my study was patients. I don't know if you have ever gone through a University of California IRB process, but putting patients through that was just not something that I wanted to go through. Especially UC Irvine, because we had so many scandals, and there was no way I was going to do that. So I really wanted to get a good perspective on the organization and get a sense of the ways in which because the doctors can tell me I hate this, and I can watch them and go, yes, you clearly hate that. But their MA can tell me something about them that I might not be able to find. And it's also really interesting, as I experienced, when an administrator tells you one thing and you turn around and you ask a physician that they told you about in a very, researcher-y way about that same thing without letting them know you talked to the administrator, and it turns out that the administrator maybe doesn't have the full story, or the clinician tells you the exact opposite, and those sources of tension are really important to understand. So methodology, I did participant observation. I gathered about 400 hours of participant observation data anywhere I could. I sat in hallways, I sat in MA stations, I sat in the record keeping areas. I went into offices when I was invited. I went into very few exam rooms, only as invited because I couldn't watch the patients, but I went to meetings, I went to steering committee meetings, I watched staff meetings, everything. I also sat through every single training session that they went through during implementation. I was there for all of their go lives. I would walk into the office and they would say, oh, look, it's the therapist, because I was there all the time and I listened to them, which I think for some doctors has become a rarity. So I did a lot of in-depth interviews. I did 49 interviews. I did them before and after implementation. And I also conducted surveys. I did a T1 and T2 survey, and I collected institutional data. The surveys I did not include in my research, in part because really the observational data and the interview data told me a very interesting story, but also because getting people to respond to the surveys, T2, was so much more difficult than getting them to respond to the surveys in T1. People were so busy dealing with the whole implementation process. Even 6 to 9 months after the fact, getting those surveys back to me was really, really difficult. So the numbers were very unbalanced, T1 and T2, and I decided to use that data at another time for another project. And I coded and now analyzed my data in Atlas TI. So, wait, let's not even go to that yet. What did I find? Right? So I went into the site when I was doing my research and I thought, what am I going to find? I'm probably going to find maybe that OBGYN doctors and primary care doctors experience it differently based on the type of practice. So I asked questions about are there differences in the types of practice that you have. And I thought about, there's all these demographic-based data that people like to make assumptions of how people adopt new technologies, how they adapt to them, right? Well, doctors hate change, right? I can't tell you, I can run down the list of things that people tell me when I talk about EHR. Doctors are jerks, they hate change, most of them are old. The old ones are the worst. They make bad patients, it's definitely true, I can tell you that for a fact. But there's a lot of assumptions that we have, right? How are these people going to experience this? And I thought, I'm sure we could conduct a study whether, if you've used a computer your whole life, all those things, but I was thinking about there may be another story and I really want to find it. So I started going through the data and this story, of course, comes out. And it turns out that there were much older physicians who fell in love with EHR, and they took to it like you've never seen. There were people who were really comfortable with computers, used them regularly, hated it. There were young doctors who hated it, older doctors who loved it. You can cut it every way you want. It's the assumptions that we make are not always the assumptions that ring true. The interesting thing, right, is that this is an organization that's recently formed. It doesn't have any traditions, and there's no move toward making it a larger, more holistic, integrated organization with an organizational culture. Because I think we have this idea that, when you do something as an organization, you are doing it as an organization, right? You know what your mission statement is, you know what your core values are, you're going to move forward as you're going to implement that technology and go, right? So that's this level up here. Then we have this level down here, which is these are the people who are going to be jerks, right? The bottom level of here's who's going to have a hard time. And those are your individual users, right? So you've got kind of it's like the expectation sandwich, right? Organizational level, individual user level. So then it turns out there's this, meet in the middle. And it is organizational culture that has a big impact on how people navigate their way through, experience, adapt to, deal with, manage the stress of technology change, right? It's organizational culture, but it's not the kind that you're thinking of. So, turns out, right, organizational culture matters, but not in the way that you think. How does it matter? Well, how do people work? Sometimes they work alone, right? They don't work, it's not like all 150 people are all working together all the time and it's great. They work in groups, right? Whether clinics, small departmental teams, cliques, different ways, like project teams, and the culture of each of those groups actually makes a difference. Especially here, because these are these organizations that have come in, they've joined, they've created this network. There's no overarching culture, and they're all operating in the ways in which they operate on a regular daily basis. So, each individual practice site had maintained the way it had always worked. That was really something that nobody had stopped to consider. There was this sort of one consideration, that site's really gung-ho, but it really wasn't that site was gung-ho, it was that site had a very particular culture of working together. And that site's different. Well, so there were these interesting ways in which, but nobody approached them in that sense. So what were the cultures that I found? So I studied 6 sites, And I identified 3 separate cultures. First was the collective. So these are clinicians, it's a group of clinicians that valued open communication and cooperative problem solving. They were very, very, very explicit about this. Like, this isn't something that I just observed. This was people, multiple people in the group told me, this is how we have structured our group. They work collaboratively with colleagues and support staff. Even when one person would have a problem, they might say, oh, that person's a drama queen or that person's difficult, but the group would really work together to make sure that person's problems were addressed. There's the battleground. Clinicians operate in a more defensive standpoint, right? Everything they feel they've had to get and they've wanted and they've needed, they have had to fight for. So it might be internal, and it might be combative with the clinicians group versus the administration. But whatever it is, there's this sense of we complain and we fight and it never happens and we do it again and then it happens, but it's not good enough. So it's just this really antagonistic attitude. And then there is the silo, right? These are your people who kind of work in these little individual units. Clinicians are really isolated. They have a very individual-based repertoire. Their toolkit is, the guy up the hall is really nice. If he has a problem, I will help him. I like the lady down the way. She's helped me. But for the most part, what's most important to me is me and my patients. And this is how we do in this office, right? And it's interesting because the silo cultures, at least one of them was a group that had been formed at the start of the organization, when the organization itself formed. So cultures can grow quickly, but people are going to use those repertoires, no matter how quickly it's grown. This is the way in which they work, right? This is a fairly newly formed clinic. These people worked this way. There had been no initial moment of saying, let's try and be a group together. They just stuck everyone in the office and everyone said, okay, I'm just going to work the way I always worked, and kept going. So here's a quick rundown of the individual sites that I did on the key dimensions. This is early 2008, so this is pre-implementation. You have your 3 OBs, your 2 primary care, your neurology, size, gender breakdown, is there a manager on site? Because for some people, that felt like, well, maybe that's the reason they work well together. And some of these are actually a little bit tricky because the no is never, there never was one. Yes meant sometimes, right? Which is that in one case, there was one site that had had 4 managers in 2 years. And it was a difficult site, but not the most. It was a lot of problems. There was a lot of turnover in the organization. We'll see about that in a minute. Location, these were all urban because I needed to be able to get to all of them, sometimes in the same day. Some of them were standalone sites and some of them were either hubs or satellites of other sites, whether suburban or urban. And then we have our organizational culture. Okay, so 1 collective, 2 silos, 3 battlegrounds. Now, all of you are thinking, that collective is all women. Found your answer, but but it's not true. Because in the organization, there was another group, and unfortunately, I didn't include in my research design. My research design was based in part on the strong recommendations of some of the administrators, and so I had to kind of choose according to strong recommendation. But I went to another site. I visited it fairly frequently, not as in depth. I did some interviews and I did some surveys there. Primary care, started by a man, male and female, also very collaborative. So put that in your pipe and smoke it, gender assumptions. It was a really interesting site. I wish I could have included it, but by the time I realized that it was too late. But they they did the same kind of problem solving, group problem solving, staff meetings that I didn't see really almost anywhere except for the other collective. So here's a quote from one of my collective clinicians, right? So there's a certain expectation, a group expectation that happens, and if you're really outside of that, you're not going to survive in this group. And there is an expectation that, this is a practice norm, and we actually have very frank discussions about that. So our group set that up. That is, we're not solo practitioners. So this was very explicitly laid out. So this is all pre-implementation. This is setting the ground so that you understand, I didn't just observe these things. These are things people actually said to me. And that I observed, because if they just say it to me, that's nice, but what people say, what people do, so forth. Then there's the battleground culture. Now, I'm going to read you this, or you'll read it yourselves. But we'll do both. And you're going to say, that's just somebody complaining, but I'm going to follow it up with another quote. So we have this clinician who tells me, Staff-wise, we've had way more turnover than we ever did in other practice. It's so often changing that as soon as I learn somebody's name, they seem to be gone. And it's very sad and I don't like it. Some of our staff that we had before were very loyal and very dedicated and would not complain and would just, figure out what you needed and do it. And I don't feel like we have that, and we haven't for a long time. So before they joined the organization of the Transitions Health Group, they felt like they had the staff they could rely on. This, was a little bit easier. It was more dependent. Now there's this incredibly high turnover, and it's really confusing. And what really brings this home is this idea from the next clinician who is outside but has to deal with this site as well because of the department that they're in. And she tells me, we've had some perturbations at OB3 in terms of staff issues, and the administration have fired some staff that were really liked by the clinicians. On one hand, the feedback from the foundation is there's just a bad culture there, and that's the culture that predates the foundation, and there's just badness. And then the feedback from the clinicians is, finally we get some people we like, and then something happens, and they just fire them because that's the thing to do. And this was repeated in all of the battleground sites, right? Oh my God, there's just this thing. We know what to do. They won't listen to us. They do something different. And the foundation's like, those people are the worst, right? We can't handle it. And you have this constant friction, and that friction builds these expectations that no matter what we do, there's going to be this battle, this lack of trust that repeatedly builds over and over again. And this is like, right? So I interviewed her in July of 2008. This is before we went live. But this had been going on for 2 years. And now you're going to go through a really big technological change. As a group, it's going to be great. Come on. Then there's the silo culture. I would call it, she's talking about her colleagues. I would call it above average. I think we get along very well. There's not as much interaction between the doctors as I thought there would be coming in because everyone's so busy and everybody goes to lunch at the same time. So I'd say less interaction than I thought there would be, but whenever we are together, we get along very well. So sort of like, my coworkers are nice, don't care. And this was sort of true. They are all like, yeah, they're really nice. I like them. I don't really, think about that very much. There was no kind of group harmony or group disharmony, one or the other. So let's talk a couple of minutes about some of the paper problems, the problems with the paper system, right? And how people dealt with them to see, does that actually translate before and after? So it turns out there was a common problem for many of the offices, right? Charts getting lost, things not getting filed, filing getting backed up. So how does the collective deal with it? Because the collective had an enormous backup in their filing. So bad that a couple days I actually volunteered to help file. One, because I felt, I did feel a little bit bad for some of the doctors, but two, because I really wanted to know how the filing system works. So I was like, I'll do it, sure. I'm very helpful. Also, it made me feel better because this was the first office I was in, and I think they still were a little bit wary of me, and so they saw me like working, filing away, and suddenly I was the really great researcher that they wanted to come every day. And it taught me a lot about how horribly hard it is to get caught up in a stack of filing. You have charts piled up this high, you've got lab reports that have come in, the doctors can't find them, everyone's stressed out, you've got these, and if you try and file during a workday, what happens? More reports come in. So you're like, I made a dent at the B's. And A through, C through Z is an A, and then more B's come in, and you're like, I did nothing all day, this is great. So the collective says, all right, forget it, this is ridiculous, we can't function, our doctors can't have, they have nothing, this is not working, the MAs, like they don't have time, we can't pull MAs off, their regular duties. We're gonna take a couple weekends. We've decided this is what we're doing, this is how we're solving it, we're gonna take a couple weekends, we'll hire a couple of extra employees if necessary, we will bring people in, pay them overtime, we will get caught up. Done. End of story. Finished. Problem solved. Worked as a group. Then what happened in the battlegrounds? Because the same thing plagued two of the battlegrounds, right? So in the battlegrounds, you had charts backed up, you had charts improperly filed, you had, in one of the sites, you had a medical records person who seemed not to know how to alphabetize or care, and just hid things. One of the other receptionists was sent to help, and she was like, one of my favorite parts of my notes is when this young woman goes and she's sent away from where she really liked to work to go try and fix the filing problem. And she was just like finding things jammed behind other folders. I mean, these are your medical records. You feel pretty good about that, don't you? So, And she was just like, this person doesn't even know that I comes after H. She was yelling in the back of the medical records, and it was a really horrible experience. And in another one of the battlegrounds, there was a very similar problem. And they would try and bring people in, and there was all of this like negative, well, you think you're better than us. And there was just this, rather than just stop, and they were fighting, they were begging the administration, please help us, we don't know what to do. One person was always going to the administration, the other doctors were like, I don't know what to do. Never got resolved. It got better. It went from like a 10 to a 3 back up to a 7 in terms of whether or not, our dictations are coming in, we don't know where our lab results are. It gets better, it gets worse, it depends on who's working. But the problem really, and they never got caught up because the battlegrounds were so, it was just this constant fighting. Whereas the collective just said, you know what, screw you guys. Here's how we're gonna solve it. And then there was the silo, and the silo was my favorite because this pretty much, this sums up how the silo behaves. Since they merged these 5 or 6 doctors, everybody brought in the way they had of keeping charts and filing records, and they just kept doing that. So I think everybody still keeps their same culture they came in with. From what I can tell between them and their medical staff, they kind of do the way they've kind of used to doing it. And it was really this kind of watching them, one of the reasons that all of their stuff was probably filed is they were just filing it their own way, jamming it in there, doing whatever it is what they did. So there wasn't this move. There were some attempts to try and streamline, but they kept failing in the silos because everyone's like, no, we're just going to keep doing it our own way. We don't want to. So, right, each office has its own way of organizing the paper record, sometimes multiple ways in each office. They have different ways of identifying what's a problem, managing the problems, resolving them. And these distinctions, turns out, shockingly, follow through the implementation process and in the post-implementation process. So here comes EHR, right? So in each context, the culture that the clinicians are embedded in influences their perceptions, their attitudes, their interactions with respect to the new technology, and with respect to the EHR's introduction, right? I mean, if you're always used to working as a group, and that's how you function, you're probably going to keep doing that, even if it's really stressful. And if you just know, I work on my own thing, and I don't know what the guy up the hall is doing, and maybe he'll help me, but he probably doesn't know any better either, and I'm not going to ask. You'll probably keep functioning that way too. And if you're just going to fight, one of the best things, it's actually not this talk, but it's too good. There was like a silent protest that one of the battleground sites actually waged. There was supposed to be on-site lockdown, right? Nobody can take any vacation. 1 week before, the entire 4 weeks, and 1 week after. You can't take any time off because you have to be here. You have to learn this. We're going to do all this training. You got to be here. Every clinician took time off during that time at different moments. So there was no point in the entire 6 weeks when all of the clinicians in the battleground site were actually present. Because they were just like, we're so sick of, there was just this, and that's the thing. And they were like, the administration was so fed up, and the clinicians were like, it was amazing to watch. And I was just kind of like, but this is the end result of a long time of frustration. And it's the end result, and it's also the midpoint and probably like the initial point of just, it's gonna get worse. So I was interested, once I figured out, this is a big thing, this organizational culture thing. How does it shape 3 specific and critical experiences? How do clinicians learn about the incoming technology? What key troubles do they identify, and how do they manage their way through it, right? Because this is what I'd seen, so it's probably gonna apply here. So it's also important for you to know some of the administration's perspective. And this is a quote from an executive. It's the first part of it. It goes into the next one. The workflow is dictated to us, to the administration. Prescriptions is a great one. Okay, we've got 50 doctors and we've got 50 ways of a refill, okay? Not anymore, we don't. Because number one is that refill will show up in the physician's inbox now. And there's no, well, I don't like it showing up in my inbox. I'd like to, when I bring up the patient the first time I do the visit. No, it's gonna be in your inbox. And it can't stay there more than 24 hours. You know why? Because we have reports that say it'll stay more than 24 hours. And we will know how long it's been in the inbox with you not touching it. Makes you really want to go to work in the morning, doesn't it? Really inspires confidence. It was this interesting thing, like We don't know how to corral our doctors. It's herding cats, blah, blah, blah. We don't know how to get them to do anything. You know what we're going to do? We're going to take this hammer and we're going to drive this nail in. It's going to be great. It's going to work. And he actually told me flat out, he said, we had a choice. We could streamline the workflows beforehand and understand what our clinicians were doing, or we could use EHR as the method through which we streamlined our workflows. And we chose the latter. Hooray. And I thought, I was like, and I'm a researcher, and as as an academic research, you go, oh, that's very interesting. And then you take your notes and you go home and you go, oh, I feel so bad, this is going to be terrible. And what was really interesting was hearing the clinicians say, well, we could have done some of this beforehand because this didn't really streamline our processes. It just shone more lights on all of the other dysfunctions we didn't know were lurking underneath the surface. Oh my God, look how many more we have. So this is what we're going into, right? This is this whole, and so when you think about the battleground sites, sometimes you think, oh, what a bunch of jerks, and sometimes you think, well, I don't know, maybe it's not so bad. So there were multiple ways in which the clinicians learned about EHR. There was the physician champion, and if you're at all familiar with EHR implementation, the physician champion is one of the most important roles. That is your cheerleader. Once somebody said, the way you describe it sounds like the chain gang leader, and I was like, no, that's really not what the way I intended. But that person is your cheerleader, right? That person is your, I'm technologically savvy, I know this is going to be hard, this is going to be a rough ride, but here's everything we know, here's how we're going to do it. I inspire confidence and trust in you, and you really have faith in my ability. The guy who was chosen as the physician champion was very nice. His colleagues said he was a very nice guy. He wrote very, very long emails detailing what was coming up, what was happening with the EHR implementation, and all of the doctors were like, I used to read those, but I haven't read them, and now we're on 37, and I don't know what's going on. And there were very few site visits. It was this sort of sense like maybe it was not the right person. So some people learned from the physician champion, but overall, those people were more isolated, right? They might ask questions like the silos generally tended to say, well, I'm just going to wait until I absolutely have to, or I'm going to talk to the physician champion. There was group training. So there was a basics computer skills class offered and then canceled without informing the physicians until they showed up. Oops. There was abstraction training. So like I said, all of those charts had to get into the system. One of the ways they did that was the charts were abstracted, right? Because you couldn't, there was just no way you could take, like, let's say you've been a patient for 50 years, some people have, and you have like 3 charts, right? To get all of that into the system for one, it's really difficult. So can all of your information get into the system right away? So they would abstract the charts, and they said to the doctors, you should learn how to do abstraction training, because this will get you more comfortable with the system, and your data will be better. And the doctors were like, you gotta be kidding me. So some of the doctors did it, and of course they had the best data because other people were hired, and that data varied from pretty good to this person says they have 1 surgery they've never had, and all of the other 8 surgeries they have had that were really important are not listed. So now I just have to redo it anyway, and I have to redo it while the patient is sitting here. Then you have super user training, and those people were meant to be, we go into the site, we go into the super using, we're part of our organization, we're part of each clinic, and we help our colleagues. And then there was just-in-time training. Just-in-time training is what everybody had to go to right as the site was going live. So you had 2 days of just-in-time training 1 week, then you had another day the second week. Everyone's productivity was knocked down to 50% for 2 weeks, then brought up to 75%, and then brought up to 100 the 4th week. That was the schedule, and that never happened, right? So just-in-time training, and then there was in-office support. And in-office support was very heavy the first week or 2, and then it kind of, they had to move to the next site because it was an every 2 to 3 week rollout, go live. So you had people that were leaving the offices, and it was really interesting because in-office support was during normal business hours. And a lot of the doctors were kind of like, but I need help at like 5 when I'm sitting here struggling. So that was also an interesting thing for the people who work in silos. They need some help, right? And maybe it's not there. So they're learning the way they're learning about it, right? the collective did a lot of group training. It's also useful to know that the OB department met every week. All of the OB groups. And there were still battlegrounds and silos in the OB department. They were very organized as a department, but then when it filtered down to the ways in which they dealt with things on the group level, there were still major differences. The primary care department met once in the entire 18 months that I was there. It was a little bit different. And so even with that difference, right, one department being very supportive, one department not, you still had a collective in both. And that still really affected the ways in which people dealt with the transition. So identifying and managing problems with the EHR, here's the collective. This clinician just lays it out. I mean, they had problems. I'm going to tell you one in a second. But this clinician says, I think we have, in general, a spirit that we're going to try and make it work, no matter what the issue or problem is. You know, we whine and complain just like everybody else, and we do a lot of whining and complaining. But the general overall spirit of this office before any of this, then she's talking about joining the network, transitioning. You know, that's what their spirit is. And so, I mean, we knew all this was coming, and it was just a matter of trying to do the best job to make it work. So when I was conducting the research, I saw 3 or 4 major meltdowns in various offices, right? I saw one in the collective, I saw at least one in one battleground, and I saw 2 in the silos. And this was a problem. There were problems that were identified by the clinicians, the ways in which they were being scheduled, the ways in which they were being supported. I mean, really, you can pinpoint it like saying, well, in the silo, it was really the prescription refill problem that was really plaguing this doctor. And it was because he had a patient panel of 5,000 patients, which if you know anything about being a doctor, a patient panel of 5,000 patients is nuts. Most doctors have between like 2,000 to 3,000 patients as their patient panel. This guy was just crazy nuts. So when he was a primary care physician, he's a family practitioner. So who does the bulk of the paperwork in the medical world? Primary care, right? And who does the bulk of your prescription refills? Like, who do you call when you need a prescription? Who do you call? Do you call your orthopedic surgeon? No, they're like, call your general, right? When you need anything, who do you call? So this guy was having like 70 prescription refills come in every single day, and he had to do them all himself. And if you know anything about the prescription refill process, you know that it is not always to the letter of the law, right? People have workarounds. That's what people do in organizations. That's what people do in systems. That's what people do even with technology. They find ways to work around so they can get their work done. And this guy was like, my MA can't dump faxes in. That's what we used to do. We used to dump all the faxes in. We can't do that. I have to look at every single thing. And the way that the system was designed was every single alert, you had to double click on it, you had to open it, you had to scroll down, you had to look at it, you had to make sure the person's information was correct. So this was taking him hours of extra work. And what he asked for is, he said, please, I sometimes have a nurse practitioner who can help me, but not every day. The other people are asking, you know, they were trying to pitch in. He was like, please, I need more support. I need more support. I need another nurse practitioner. I need another nurse, an advice nurse. We need someone. Nothing. Eventually, he shut down the larger half of his practice and just went and practiced in this urban setting. That was it. So his physician exit, right? Battleground. What's going to happen, right? In that culture, you're going to fight, you're going to fight, you're going to fight, you're going to fight, you're going to lose. And then you're going to quit. And that's not really the best. And he actually was fine. He's like, I like electronic health records. I think they're great. I can't work like this. So that one comes up. I skipped ahead because that one's really good. But this one's really good too. In the collective, there's a nurse practitioner. And she is overscheduled, right? So a lot of the nurse practitioners would see the new OB patients because that's, you know, nurse practitioners don't do surgeries. They come in, and the OB patients, they would do the initial OB visit. And a new OB patient is an hour-long visit, right? All the men are nodding sagely. It's pretty awesome. That's pretty sweet. So it's a long visit, and they had scheduled her in the very beginning of the EHR rollout. They scheduled her one day, 3 OB patients in a row, 3-hour-long visits in a row. No breaks to catch up on her charting, figure out what she was doing. Nothing was prepped. Everything was a mess. She totally lost it. Like, she just broke down in tears, crying, slamming her office door. Total freak out. This is in the collective. So what happens? Her MA is like, jump us up. She's like, well, I have to help. The other MA is like, what's going on? What can we do? Let's fix this. One of the other doctors runs down the hall. She's like, what's going on? finds out what the situation is, enlists one of the other doctors to make sure everything's okay, make sure other needs are being met, goes up to the front, says, this is what's been scheduled, this is not acceptable, this is how things need to happen, we can't function like this. This person's schedule needs to be changed, let's find a better way to do this. Problem solved. Okay, then there's the silo. Same thing happened. There were 2 different doctors who felt completely just overloaded and overwhelmed. One particular case, the MA was really difficult and could not learn the system. In fact, another clinician sat down with her for like 40 hours of work trying to get her to learn the system. She just couldn't do it. And this was trying to support one of the busiest doctors in the silo practice. Actually, the second busiest doctor after the guy with 5,000 patients, the second busiest primary care physician. Couldn't get it. There was an OBGYN nurse practitioner having similar problems in another silo. And what happened in those silo cultures? Everyone's like, oh, that's the crazy person. Don't want to be bothered with that. And they just left it. It was like there was no support. There was nothing offered. They became known as the difficult ones. And they just felt like completely thrown to the wolves, right? So that was the ways in which these cultures navigated their way through some of these problems. This is actually another one that I like from the silo. She says, people have asthma, so I'm like, I've been doing a nebulizer, how do I do it? And how do I do the nebulizer and the albuterol? I don't know how to charge for it. And she says, I actually emailed one of the coding people. I said, I don't understand this. Could somebody come up and show me, or if somebody else in the office has learned this, that's great. Could you direct me to them in her own office? Could you direct me to them and I'll ask them? I think that's actually pretty nice. And I said, if nobody else in the office knows, if you show me, then I'll explain it to everybody else. That's the first half of the quote. This is so silo, right? I don't know if anybody else here knows this. Because how would I know? We don't ever talk to each other. And I'll tell other people, which is really nice of me. I'll go around and I'll teach people, but you have to tell me. 6 months later, I still don't know how to do it. Could somebody come out, call me on the phone if you just cannot leave your office? Or something? That to me is pathetic. And I don't think anybody else is doing it. I think everyone is doing something different, and I think they're losing tons of money because nobody knows. Right? So she doesn't push for it, she doesn't fight for it. She's not like in the battleground. Seriously, I saw meetings with battleground clinicians. Totally different. They're like, you promised that you said we would not lose our charts, this is happening, and this woman's like, I don't know, 6 months later, I don't know what I'm doing. I'm just gonna keep doing it my same old way. You could tell me I'm wrong. Right? I don't know what the guy up the hall does. No idea. And this is the guy with the refill problem in the battleground. He says it's no longer the protocol. It's like, because legally, it couldn't be the protocol. They can't have MAs going in. Even though technically, legally, under California state law, MAs can refill prescriptions, but it has to be under direct authorization of the physician, and it's really difficult. How do we know that? But that is an accepted workflow, and it's a legal one, but it has been totally wiped out, no longer allowed. So he says the MAs have to look at the charts too, because remember, all the data is difficult. So their work increases. They used to just dump the fax in the machine. He was here until 9. He can get up to 70 refills on a Monday. He said at 12:50 he had 33 refills. I mean, that's a lot of work, right? He fought and fought and fought. Eventually, he just left. So, what did I learn? So this was a newly formed organization. Yes, this was an organization that had more than its share of dysfunction, right? But is that unheard of? No, lots of organizations have their massive. Everybody is nodding, going, "Oh my God, I had a long day," right? But you have this organization with very little unifying organizational culture and structure across the organization as a whole, and there's no move toward making anything like that. So the clinicians continue to operate within their pre-existing cultures, right? Whether pre-network or pre-implementation, like the silo was, had a culture that had only existed for a couple of years, but boy, did they stick to it, because nobody came in and said, could we work on this in a different way? Or it wasn't even possible to do that. I expected the clinicians would experience implementation differently based on, their specialty, whether primary care or a surgical specialty. There were differences, but the culture of the differences, part of it is OBGYN uses somewhat different software. Primary care, they have a lot more refills. So it's kind of hard to say, do you have more problems or different? I mean, yes, they'll have different problems. They do different work. So it was important that I learned that organizational cultures can develop quickly and they can change, right? Because that's really important for thinking forward. Culture will affect your experience of the technology, and the new technology can affect your culture and the ways in which you interact, right? If that technology, I mean, if that culture can form in 3 years, if people are like, this is how we do it, because you might be thinking, well, they just operated in that silo, but they weren't really, they were just operating as solo practitioners. They're supposed to be working in a group. So that's their group culture now. We are people who work together in a group, but not really. And that culture formed pretty quickly. So cultures can form and can change. Organizational cultural settings provide the necessary toolkit for creating strategies of action in a variety of contexts and contingencies. And these strategies of action, they are profoundly different, and they provide profoundly different experiences and behaviors that affect the long-term adoption process. And that, I think, is really important to think about when we think about how we build technology, how we implement technology, right? Context matters. So my recommendations, just at the end of my dissertation, was you can't, I mean, nobody has 18 months to go in and go, oh, I observe my clinics and see if I can't change up the culture a little bit. You probably have like 3 days. Just try and identify the culture of the clinics. And be willing to create a support system that has the ability to work with each culture. Like, if you know you have a real collaborative culture, let them be collaborative. Why would you fight against that? If they want to have ideas that bubble up and work with you, they want to work with your workflows, they want to understand them better, that is a gift, right? If you've got this battleground culture, maybe before you get engaged in another all-out war, try to understand if there's any way to resolve some of the skirmishes past. And in some ways, you know, of course, the underlying subtext of that is maybe the culture will change, right? If suddenly they see you're not just giving lip service, you're not just saying, oh, we're going to do everything differently this time, and then it's just the same old war, and you've also not dealt with any of the problems that are still remaining from previous issues, that might actually improve the culture. That could change your negotiated order, right? And then the silo, I mean, if you have like all these people sitting in their offices, no idea what the guy up the hall is doing, make sure you have the proper support at least to be able to support those people. And then be willing to conduct evaluations during and post-implementation from the standpoint of all the cultures, not just we're going to do it in the beginning and then we're going to stop and now have at it, whatever your culture is, but follow through all the way. So what I'd like to do next, I am really interested in this idea of technology in context. I think that a lot of times it's really easy to stop with, you know, the end user. Like, how does the end user experience your technology and adapt to it and navigate their way through it? But we all use technology in context. I mean, how many articles have you read lately that are like, people are still stealing iPhones on the Muni, right? That's technology in context. That is not just your, in fact, that is your end user leaving that context and going so far into another context that they totally lose sight of where they are. So I'm really interested in that. I mean, and from the healthcare perspective, because primary care, I mean, can we relieve some of the burden of their paperwork? Not by giving them more work, but by giving them ways to work better. This clinician-patient connection, I think, is a big thing, that is a big problem. That's something that I'm really interested in. Can technology, rather than saying we should just replace all doctors with computer systems, which, you know, some people find very tempting. Sometimes patients are difficult too. Sometimes we're all difficult. How can we improve that connection? Can technology help improve that? You know, in the healthcare industry, a lot of physicians and clinicians are faced with the possibility of unsustainable practices. And one other thing I'm really interested in is, can we design technologies and implementation processes that take into consideration the different ways in which people work, and also the different ways in which people need healthcare, right? Because it's really great to say, well, managed care sucks, and health insurance, you know, all of these risk pools are terrible. We should just have all of these, you know, like, you know, critical care clinics and blah, blah, blah. And that, yes, but let's say you get a really bad long-term disease, right? There are different types of health needs that we have and different types of providers. And how can we create better systems to support them? So, if you have any questions, I guess 11 years later, I'm still Ask Leah. And My website, don't click on it till Friday, because it's still under, but it'll be ready on Friday. And that's my email. And if you have any questions, I'm happy to answer them. Thanks.
Hi, thank you. I have one sort of statement and then one question that are pretty different. There's a book called Tribal Leadership that talks about 5 stages of tribal performance, and actually your collective, battleground, and silo match up like almost perfectly with 3 out of their 5 stages. So if you haven't taken a look, I think you should definitely, I think everybody should read this book, by the way. It's pretty amazing. I'm not getting paid to endorse that or anything.
I'm not shilling.
My second question has to do with medical advocacy, and if you see medical advocates somehow fitting into that picture of technology, EHR.
Are you talking like patient advocates?
Yeah, like patient advocates.
Okay, yeah, absolutely. No, absolutely. I had a very, while I was writing my dissertation, actually, I was the primary caretaker for someone who was going through a very significant course of treatment for lymphoma. Chemo, stem cell transplant, the whole 9. So I got to really experience the healthcare, and also this person is a doctor, and I am her daughter. So I have seen the healthcare industry from a lot of sides, and I think patient advocacy is really, it's like, it really showed me the importance of patient advocacy, right? And the ways in which the healthcare system can really do great things, and it can fail so miserably you cannot fathom it. And I think that there are a lot of ways in which patient advocates can be a part of this, because I think it's really hard, right? We have all these HIPAA regulations, we have all who's allowed to access what, who owns your data. You know, there's this whole open notes movement that I think is really interesting, because patients are like, that's my data. Yes, your medical records are your data, but I actually think of the medical record as a collaborative document, right? Like, your medical history is certainly your information, but when you create a medical record, you're actually creating a collaborative document. You're working on something with your doctor together. It's also a legal document for the doctor to cover his or her ass if necessary, right? I mean, I can't tell you how many doctors are like, this is totally so much of this, like if I don't write it down, it didn't happen, right? So I think that, you know, we have all these issues that are coming up, but I think patient advocacy it's so important, because I think that, I mean, I liken navigating the healthcare system to being dropped off in a foreign country with very little money, you don't speak the language, you don't know anyone, and also you're naked, right? So, I mean, being a patient's really hard. So having a way in which we can, I mean, I am very much like, I like to think of the whole system. EHR is just one piece of it that I was able to, you know, finish my PhD eventually. And I think that you can't necessarily do one piece of it without thinking of how all the other pieces fit in, and patient advocates are super important. They're really important, and not just when you're really, really sick, but sometimes you can't, you know, you need help to navigate that system.
Hi, so on a sort of related note, I'm curious if lately it seems like at least a lot of anthropologists have been studying these ideas of connecting patients and doctors in more, I don't want to say traditional ways, but really having conversations. And I'm wondering if this new if EHR technologies are starting to be seen as the sort of superior future of being able to see data, does it start to overemphasize the value of that data and possibly actually, like you said, fracture the relationship more?
That's a really good question, and I think it's a real complicated one to answer. I think part of, you know, there is a lot of value in big data. We can understand the ways in which patient populations change and shift, right? I also think that, you know, so EHR is just a tool. I mean, so I'm really, in sort of where I come from in my personal philosophy is that I don't think there's any sort of silver bullet that solves the whole problem. I mean, it would be great, but I think we as humans are like, where's that thing that's gonna make everything better? And there are a lot of processes that don't work, and there are a lot of processes that do work. And maybe not as many as don't, but that's another story. And I think that, some of the focus on the big data can be really, really useful. We can learn a lot from it. Epidemiology, we can learn a lot about our patient populations. We can learn a lot about what people do and don't do. And I think it can also tell us and help us understanding more about preventative care rather than just, right? Do patients do these things to take care of themselves? Do they not do these things? And I think that EHR is the electronic health record. It is just a piece of this healthcare, of this health IT, that there are some people who worry it will make people more disconnected, right? Doctors who feel like it's very cookie cutter, they have to enter in stuff into templates, so forth and so on. And I think that it is really important to keep an eye on. Like I was reading today, because that whole Qualcomm thing about we'll give you $10 million if you invent the Star Trek tricorder. Should I see that? Yeah. So Qualcomm is offering $10 million prize if you invent the Star Trek tricorder, like to scan yourself and self-diagnose. And I actually made the joke that was like every time I use the self-checkout at the grocery store, I cannot imagine anything that could possibly go wrong with using a tricorder to self-diagnose. I think it's a really cool idea, and I think like doctors use algorithms, right? You run through the algorithm. If this goes to this and this and this, is it this? If this goes to this and this and this. And I think that we can use technology to improve healthcare, but I think it's like we look at so many things in terms of an either or. Should we use technology? Should we use the human connection? It's like saying, should we use Western medicine? Should we use Eastern? Everything, is a tool. Which tool you emphasize, maybe it's not a matter of emphasizing all the tools, but providing all the tools to people and saying, use the different ones, depending, it's like your strategies of action, right? So I think there are ways in which they can improve the communication between doctors and patients, and there are ways in which they can harm it.
This is, so your research was a kind of a window on a larger movement or enterprise, which is the entire healthcare industry needs to implement electronic health records, yes?
Yeah, it's sort of like the jumping off point to other research. It's a case study.
So I don't know if your three categories of culture, collective, silo, and battleground or will be universal or whatever, but do you know, have there been identified best practices for supporting or for the process for, say, a battleground culture and a collective culture, or for any culture? Are there best practices?
I think there are best practices in terms of implementation, right? Ideas of best, there are different types of implementation depending on which system. Are you implementing Epic? Are you implementing, next gen? Like, what are you implementing? There are best practices, and then there's this whole idea of meaningful use, which is intended to make your use of the electronic health record more effective, more efficient, less paper-based. Then you meet these standards, right? But it's not based around the organizational culture, the idea of how people work. Because that was really what I was interested in. It's kind of fascinating. To me, the incredible push that has gone on to implement electronic health records. And we can argue whether or not it's needed, that's a separate discussion. And the sort of real sort of disparate, scattered research. And there are lots of other researchers. I'm by far not the only researcher who has done this, but there have not been before this a lot of social scientists researching into this. There was a lot of research done internal to Kaiser, but first of all, Kaiser doesn't release a lot of its research. And second of all, researching Kaiser is it's like another country compared to small ambulatory care sites. And not a lot of people there had been very little, if any, research done on what is this like for physicians. There had been some self-reports. Doctors saying, okay, so we're a group of 4 people and this is what our experience was like. But there really so I can't tell you if there are best practices based on these cultures, because I don't think there has been research done like this, based on, at least not in health IT. So it would be interesting if we could develop those best practices moving forward. And I think these are just some of the cultures. I'm sure there are others, but I also don't think they're just applicable to health IT and EHR. I think that we all know and have worked in organizations where there was that really great collective group, and we wish we could be a part of it rather than with the people who were always fighting with the administration. Such is life.
question. My perception from listening to your talk is that they didn't consider the end user and the user experience when they designed the technology. So the end user is the doctor. And when I heard your story, I just felt a lot of compassion for the doctors. And my perception was they weren't considered. And then as the end user, me being the patient, I thought, wow, I would want to see any of those doctors because they'd be so frazzled, not at their own fault, by what's going on, and their core competency is healthcare. And that's what they should be concentrating on, and the technology should be centered around how to help them.
Yeah. This is one, it's unfortunate because this is one example, and that's why I tried not, it's hard because when you're talking about it, the dysfunction is apparent and the difficulty with the software is very apparent. But this is very much a widely used software. This is not a small one-off. This is a very, 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 one of the big ones. And I don't think this particular one was ever designed with the end user in mind, or the doctor. I think it has been modified using a lot of subject matter experts, a lot of doctor input. But the problem is as well is that a lot of the original generations of electronic health records were designed for hospitals. And if you have ever been in a hospital, you know it is different than your doctor's office. We could do the research, I could tell, we could talk about it as experts. But it's so obvious that there are different ways of functioning, there are different organizations, and there are different needs that doctors have. I talked to someone the other day who left medical school because he didn't want to be an inpatient doctor, and then he realized that if he had gone to school for ambulatory care, it probably would have been a very different universe. They're just culturally, they're different. It's very interesting that you said it gave you a lot of compassion, because after I went in there, so, my mother's doctor, as I told you, and for many years I thought, oh my God, she just complains about her job all the time, whatever. And then after 18 months watching how hard doctors work, it really gave me a different perspective on how the medical world functions and doesn't, how hard a lot of doctors work. It's a very difficult time right now because I think there's there's all this anger at teachers, right? There's a lot of anger at doctors. They're the very public face of healthcare, right? They are not, to us they are, and to them we are. And so there's this anger directed at them, and then it occurred to me that, in every profession there are a bunch of jerks, right? And you unfortunately might run into a couple of them in healthcare, and they will color your whole experience. And a lot of these doctors are working really hard in a very difficult system, in a system that doesn't necessarily train them to be team players and enable them to work with others. Playing well with others, not part of the curriculum of medical school. And so these technology systems are sort of like some of the older ones. I think some of the newer ones, because I've seen some of the newer ones, and they seem to be much more designed, at least with some more emphasis on the end user, on the doctor, and then understanding how that will affect the end. But this is what I wrote actually in the conclusion of my dissertation, which is that, and one of the things that I've been hoping to do moving forward, which is that I don't think you can have happy, healthy patients if you have absolutely miserable doctors. And I don't think we're going to get rid of doctors that quickly, as much as maybe some in the and some in the world would like to. And the thing is nurse practitioners are just going to be just as miserable, and I think they can all work together. I think there are so many ways in which the system can change as a whole, but if we just design systems that don't have them in mind, I think that's where you end up, is with people thinking, wow, my doctor is even more of a jerk. Great.
So I was going to ask one question, but I'll ask another one now. And the one I was going to ask is if you ran into a microcosm of a battleground person in a collaborative environment or vice versa. But I won't ask that. Did you find resistance to adoption of electronic records, a hidden agenda there, and that doctors felt they couldn't hide their mistakes as easily? Or to put it another way, is there such a thing as a no-fault collaboration between doctors where one can say, I think I screwed up here, Joe, how would you handle this case?
to address that last part of no fault, I think, that's really difficult because so I was, sorry, anecdotally, I apologize, but I was talking about medical school with someone the other day and how the way that many doctors, there has been a move recently to introduce teamwork as part of the curriculum in medical school. There's been a movement to do that, but a lot of medical school is, you made a mistake, now let's publicly humiliate you, right? You're a jerk. Who's the jerk on the team today? And I think that for people who already have fairly healthy egos, that just creates a really difficult barrier between you and others, right? I mean, you are going to be, it makes you, and I don't mean healthy ego in the bad way, I mean healthy ego in the good way. Like if someone's going to make a decision about my life and or death, I would like them to be fairly confident and not be like wishy-washy, right? So that's a healthy ego. But if you've got this sort of, you're an idiot and let's publicly humiliate you and make you feel stupid for your mistake, you don't want to admit mistakes, right? Does that engender in you a desire to admit mistakes publicly? No, right? So I think EHR maybe involves how can we deal with mistakes in the electronic health record system, but I think that is actually a larger problem that needs to be addressed. What was the other part of your question? There were certainly people who took one line of notes. I didn't look through all their charts. I mean, the HIPAA regulations, I helped file, but I was helping file because I was really interested in the process. But I didn't look, I did ask people. One of the sections of my interview was, what does the chart mean to you? What does the chart represent? What does the chart have in it? I asked about notes. Some people are incredibly diligent note takers, some people are not. There's not really a sense for them about whether or not better notes mean better care. And then there was a sense that some people were doing things that were possibly wrong and bad practices. And only really one of them was doing such bad practices that I think he in particular as an individual was fearful. But I didn't see any microcosms per se. I think that some of the things that you might like your EHR to catch, like if you have a doctor who never, ever, ever touches you, even when they say I did a physical examination, and it's pretty hard to do a physical examination if you don't touch the patient, how can you catch that in the EHR? You can say just as easily in a computer as you can on a piece of paper, touch to the patient. So I think that, some of the problems, there was really one clinician who seemed, rumor had it, that this person was doing a lot of illegal things, with, saying they saw patients for the highest level visit, and they saw 4 of them in an hour, and the highest level visit is actually a 45-minute visit. And we all are, I'm actually pretty bad at math, but even I can do that math. So, no, I think there are issues around it, but I think the thing is about doctors is there are people who don't do their jobs very well, but there are a lot of people who just want to be able to see their patients. And, there were doctors who would work, they were working from 7 in the morning till 7 at night, surgery at lunch, calling patients and insurance companies in between every visit. One doctor's like, I don't think I peed today. It's 6, been here since 7. And giving them these technologies, are we making it harder? Which ultimately is going to piss us off more, excuse me. But, how many times have you been sitting in the doctor's office going, it has been 45 minutes and I have wasted my whole day, and then you go in there and you say, you wasted my time, but now I want my whole 15 minutes even though I complained to you for 5 minutes. Plus I'll probably take another 5 to tell you about something I'm not supposed to tell you about, and then 25 minutes later you wonder why your doctor's running 45 minutes behind all the time. It's like a system-wide problem. I think patients and doctors, I think on both ends, it's just it's a really frustrating experience. So. Oh, right up here.
So I've worked in the healthcare field. I was wondering if you were, before these programs were trotted out to all the disparate practices, if anybody gave them the dog and pony show about how electronic records will drive down a lot of errors. There's a lot of errors in medical records.
Right. There was a little bit of, there was talk about, so one of the questions, the sections again in my interview, so my in-depth interview, I said, why do you think electronic health records are being introduced? Because I don't, I didn't want to say, did they give you a dog and pony show, right? I really wanted to ask those sorts of questions, but I had to ask the least leading question. Why do you think EHR is being installed here? Why implemented? Why do you think this particular selection has been made of this, vendor? What do you think it will improve? How do you think it will change things, so forth and so on, to see if any of that, because they didn't really there wasn't a lot, there was some like, oh, here's a demo if you want to see it. I mean, there was very little, until well after implementation, this was a common complaint. Administration was very rarely seen in the offices. Like, they were like, I never see that guy. Like, the physician champion, they were like, I've seen him twice since implementation, I never saw him once before. And a lot of them didn't say anything about, they said, oh, it collects data better. Most of them said for billing. Collecting data, but driving down errors and efficiency. I think, and I think it is important to remember too that a lot of these interviews I was conducting in 2008, I mean, it seems like not that long ago, but in terms of EHR and the ways in which it's been presented, I mean, even in 2007, 2008, there were so many articles that were just like, will it, won't it, drive down errors? It will, but then it turns out it doesn't. It turns out you're going to spend $1 billion and you're never going to recoup that money. For a lot of people, most people just felt like we're doing it for the administration. We're doing, not most, a number of people felt we're doing it for billing. We're doing it, and I think that the education, and there was, like I said, these long physician champion emails that would go out. And that was really about, there were a couple other, demos that were available, but nobody went around to each clinic and said, here we go, here's what it looks like, here's what it's gonna do, here's what's gonna happen, let's run it down. It was like these emails that went out. It's gonna be great. It's gonna be hard, but it's gonna be great.
A comment and a question. The comment, I'm a nurse, and I can tell you that our work has been profoundly affected by the introduction of the EHRs or EMRs. I'm also a programmer, and when I use Epic, for example, I think, wow, this is some really great software. But with my nurse hat on, the time and motion studies have proven repeatedly that actually we spend more time in front of the computer than in front of the patient. That is literally true. My question is in regards to the characterization that you did of the docs into their cultures, into battlegrounds, silos, and collectives.
Mm-hmm.
Would you characterize the cultures of the nursing stratum of the healthcare system in the same way? Or?
Well, so these offices did not have nurses, they had MAs. So that was a little bit, the nurse practitioners and the physician assistants I included in the clinician group. I included them with the physicians because nurse practitioners do the work of the clinician. They come from a different philosophical background and different training. But many of them do the same work as physicians. Not 100%, they do similar work. And PAs do some similar work, not to the same level. So to me, they were healthcare providers, right? I just said you're all healthcare providers. There are many more physicians. And I had initially been interested in the physician experience, and then I realized we have other clinicians, but by then the title was in grants and so forth, so I just kept it. But that's why in my presentation, I really make sure that it's clinicians. So this office did not have nurses. And the problem is there's a huge difference between a nurse and an MA. I mean, MAs are not trained. They have very, very little training. They have some training, very, 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 very basic training. They have no prescriptive authority except to do refills under direct supervision. Like if a doctor says, you hand them, and you're an MA and you hand them a doctor a piece of paper and it says, this patient wants this refill, and the doctor says, okay, that's called, right? That's supervision. If the doctor cannot say, here is a protocol list, and if a patient calls in and wants any of these prescriptions, call it in, which a lot of offices do, that's not legal. But nurses are different, and so there was only one advice nurse in the entire thing. She worked in one office. She had worked there a long time. They just brought them with her, and so I couldn't really include her because she's not really a stratum. So I don't know that. I think it would be really interesting to look at the nursing pool. I mean, the MAs, there was such incredible turnover. since my focus was really on providers and clinicians, I think it would be really interesting. I think it would be really, really interesting to look at not just the cultures of the nursing stratum, but how they interact with the doctors and how those systems function. I think that would be really fascinating.
I was curious more about the relationship. There was a mention of user experience and how that relates to this, but your talk focused a lot on culture and dealing with the transition to the system, but were most of the complaints about the fact that they have to use an EHR and what the stringent requirements of an EHR are, or were they about the specific EHR they were having to use? Because the user experience thing, when it comes to developing the software, has more to do with
The specific.
how did you implement it.
Right.
But in order to take a specific example of prescription refills, to be SureScript certified or ONC certified, you have to follow certain standards of how a doctor handles a prescription refill.
Right.
You can't just have a list of them
Right.
and say, approve all and click
Right.
OK. That you have to go through each one, verify the patient's
Right.
information, verify the prescription, verify the dosage, match them to the specific record and in the system. So that's more my question is, were they complaining that they had to use this at all?
No. The thing is that they were complaining about, there were definitely complaints about the specific system, and there were a lot of individual level complaints about it. This was not maybe the most user-friendly system on earth. And this is why I use the prescription refill. Is not so much, because a lot of them were fine. Once they got the data populated in the system, so there's also, as you know, the difference between filling a prescription and refilling a prescription. And a lot of the prescription refills would come in their inboxes, and the ways in which, before they kind of figured out a better way to streamline this process, it would be every single refill, whether it was from one patient or the same patient had 7 refill requests, every single one was an individual message in the inbox. Rather than one patient has 7 refill requests, and I can at least do them, make sure everything is matched and click everything, but having to open every single one up, scroll down, make sure the information is correct, does it match what's in the chart, is the chart correct, so forth and so on, going through. That was, for that doctor, it was just, that is a lot of work, right? And I think there were complaints, there weren't so many complaints about having to use, there were some people who were just like, I don't want to do this. And there was one doctor who dictated his emails. So before EHR implementation, but you're always going to have your outlier, right? You're always going to have your one guy who's like, never, right? Don't use them. And there were people who there were some people who were angry about EHR in general, but still very computer savvy. And I think, so since I did focus more on how people, regardless of what the complaint they had, how do they navigate their way through it? But a lot of the complaints, so I did gather data on how people experience this particular software. And this software was very user unfriendly. There was a lot of clicking. That was one of the biggest complaints. I have to go click, 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 click some more, and then I get to the screen, and then I have to click again, and there's all this clicking, and I just hate it. And, it's this idea that, I think when we think about a program like it, let's say you have to click through something and you have to do it once. And that extra series of clicks takes you 20 to 30 seconds, right? And you're like, oh, what a pain, right? Now imagine you have to do that for 30 patients at the end of the day after seeing patients, and that's just one step, right? So something has taken you 20 to 30 seconds, you have to do it for 30 patients, and that's not the only thing that takes you 20 to 30 seconds. Now add all that time up at the end of your day. That's a lot of time. And the ways in which this had been designed had seemed to just been, it was like there were, screens. Did they know exactly what the screen was? Could they X out of the screen? Could they hit cancel? Could they say override it? There were things they couldn't override. There was no way, there was just this feeling like I just figured it out eventually. And then the system was so incredibly complex that there was like continued training, that they weren't paid for. That's the 6-month mark or the 3 to 6 month mark, there was like another level of training to help them level up, basically. They didn't call it leveling up training, but I wish they had. There were a lot of issues with the software itself. But in order to do this, I just looked at, okay, so now that you've identified those problems, do you offer support to your colleagues, or do you just go, whatever, I don't care? Like the woman in the silo who's like, I'll change it if you want, but you got to tell me, and I'm not, I don't know what anyone else in this group. And actually, what was really interesting was the OB collective. So this system used a lot of, there's a lot of phrases that you could use, and you could, text expander sort of thing. And they just felt like, oh my God, we have so many, what do we do as a group? What are some of the processes and forms that we've used as a group? And how can we replicate those in our new system? Because the way that the system is designed is not very friendly to the way that we do our work. And so they sat down and they came up with a way in which they could share all of their text expander sort of smart phrase sort of things. They came up with a way to, sort of navigate around some of the issues of the software and make it more functional for them. And then they took that up to the departmental level, which, if your collective is going to do that, let them run, right? I mean, hopefully we can design software that avoids some of those issues, but I think that this one was just not designed that way at all.
Hi, so I was just curious, I'm presuming that the research you looked at, clinicians weren't using any kind of mobile devices?
There was no mobile. It was all in their offices and in the exam rooms.
Yep. So
and they wanted mobile really bad, but they were like, no, that's too expensive and you can't recharge it and we're not going to give you mobile. No, there was a decided no on the mobile.
Okay, so based on your research and the culture that you saw, just speculating, how do you think would mobile be something that would alleviate some of these stressors for clinicians? Or
I think that mobile. So one of the things that I did observe that I didn't talk about was having. So some people felt really comfortable typing in front of the patient, right? Some people didn't. So then the people who didn't would sometimes run back to their office, right? So when you observe, like when I observed in one of the things that I really liked the best was in some of the offices, there would be like an MA station that would have like a podium, but it was like a counter, but it was kind of this high, or they would come up to the reception area, and the physicians and nurse practitioners would put their charts down and they would fill them out, right? And they would all stand there and they would crack jokes to each other, they would talk to their MAs. And it was kind of almost a social thing, right? They would at least fill out the encounter form, which is how you get billed. They would fill out the encounter form and they would all stand there and they would take a couple notes, they would do it, and it was kind of like, rather than going back to their office every single time, there was sort of a central place that a lot of them would come to. And after the implementation, of course, you never saw them there because they were all like hunched in front of some computer going, oh my God, especially like in the first month, they were like, oh. And then that calmed down, but you didn't see them in that same place. And so that was an interesting, and I don't think that was a workflow that people thought about in terms of how systems work, which is that a clinician will come out of the room, might take a couple notes, then they might stand here with their colleague and their support staff and talk about some other things and ask some other questions and fill out something, fill out the form, and then go and move along. And I think mobile would have helped in some cases. I think also some people would be more comfortable. I also think it depends on the type of mobile. Is it the type of mobile you can write on? I mean, I don't know if my handwriting is legible. And some doctors have terrible handwriting. Some doctors, anyone who's worked in the healthcare system is like, yes. Some doctors have fairly legible writing. And the other thing too is it going to be typing? What is it going to be? I think how people do work. I mean, one of the things that we were talking about at dinner was that how you perceive data. I think one of the things I like about mobile is that I can hold it like this and look at it in terms of this way. If you think about what your medical record looks like, it is a chart. You hold it like this. I am a person who, if I don't write something down, like do this motion, I don't care. I'm sure if I tested it with tablet, maybe it would work. I haven't tested it. Grad students can't afford tablets. But if I don't write it down like this, I don't remember it. If I type it in my phone, I can tell you right now, my to-do list in my phone, my electronic to-do list, has stuff in it from like November. Because it's just right out my brain. And some people are really comfortable in this environment, right? With like a window and some fields and scrolling to the next field. Some people, it is a really good environment for them data-wise in the way they function. That I think that there might be something with the tablet where you go, oh, here it is. Like at least I might not be able to spread it out to the degree that I would like to, but at least I'm perceiving the data in a way that feels more natural to me as the way I have been trained. I mean, I don't know that, that's just an assumption that I have, but I think also in the types of workflows that I saw where, you know, it's not a workflow that you think, if you ask someone, tell me about your workflow, how do you know, like, well, I get the chart, I do this, and I do this, but are you gonna remember? Then I go and I stand at the MA station and I crack jokes with the doctor down the hall, but I don't ever see unless she's also standing there filling out a form. And then I talk to my MA and I ask her to make sure she restocks something, right? So I think that's like a part of a workflow that it's hard to remember. Because I mean, if I asked you, like, how does your day go? You wouldn't be like, well, then I pass by Jill's desk and ask her if she, wants a donut because there's some in the break room. But this is an important part of my workflow because on the way there, then I remembered this thing I needed to do and so forth and so on. So.
Last question.
I was going to say, it seems to me like the question is really directed at the medical EHR health system itself, which you didn't have any influence on. It was just there, and that's what you were researching.
Mm-hmm.
But it's an uphill battle, because if you study anything about individuals and how they work, there's a number of different systems, but one of them divides people into 4 buckets.
Mm-hmm.
And the first bucket is, let's say, expressive. The next is driver and analytical and amiable. Well, 3 of those groups hate organization.
Right.
The driver will do it and only to be efficient. The other 2 don't care to do it at all.
Right.
So you're asking at least 50% of this group to do something they wouldn't do anyway.
Right.
And one of the things that I do when I walk around an office is you can see just by how people keep their desks as to what kind of personality probably they've got. If it's piled high, then, they're probably amiable or expressive.
Thank God.
I mean, it's a sweeping generalization, I know, but it does seem to me like the electronic health records have to take that kind of thing into consideration in terms of user interface. It has to be just as simple and as time-saving and give them benefits. Right now, it doesn't sound like it gives them benefits. It just takes time.
Right. Well, I mean, one of the things that I think about too in terms of the ways in which we think about systems design is just like with the electronic record. If you walk into the back area of any doctor's office, like you look at an MA station, right? There's going to be stacks of charts, and they're not just. Sometimes you look like, oh my God, what a mess, but it's not. They're actually those stacks of charts mean something. One is going to be labs that need to be refiled. One is going to be prescriptions that need to be refilled. One are patients that need to be called back. One is something else. And the ways in which, it's like you can't have Leah's electronic health record system. As great as it would be, I would love to be like, this is the way I do work. Okay, go, right? And I'm not even that kind of doctor. But, I think it is a matter of saying, it's this interesting idea that we have such a huge population in this country with such a variation in terms of how people have been trained and how people do their work, that they're at some level understanding, okay, this not just all of these legal requirements, it's not just all these technological requirements, but you are using them in context, right? You're using them in an organization that you work in a particular way. So what are the ways in which people work? How are the ways in which they do their work? And how can you can't always just mirror a process, right? You can't say, well, you get to stack up your papers in a way that's comfortable for you on the computer. You can't mirror the process back and forth, but is there a way you can, and a lot of people unless I do it the exact same way, I don't want to do it. Like, unless it exactly mirrors what I do, I don't want to do it. But is there a way to talk to the person and say, we're not going to be able to replicate your work process. We are going to try and provide something that is similar and hopefully more beneficial. We don't want to, because one of the things I think that is really interesting is the ways, the kind of one of the classic ways of looking at workflows, which is task, resource, actor, right? It's that the little triad, right? There's a task, there's a resource or a set of resources, and there's an actor, and it could be a person, it could be a group of people, it could be an organization, right? So anything you do has to involve you doing a thing with an object, right? And if it's a new system, you're breaking some of those connections. And how are you reconnecting them, and how are you reconnecting them? And if you're not reconnecting them and people are really, really hoping you're going to reconnect them, it might be important to explain to people why you're not reconnecting them, or giving them an alternative so they feel like we used to work on this as a group, now I have to work as an individual. Is there another connection that I can build there? Thank you.